Hello students, welcome to the Cardiovascular System Part 2. This lecture will focus on the blood vessels of the cardiovascular system, and sadly and unfortunately we do have to memorize the names of some of the important arteries and veins in the body, so we'll do that later. In this lecture. And again, I'm sorry that the cardiovascular system takes up so much space in the lecture, but normally in the course, but normally we would have an extra week, so this wouldn't feel quite so overwhelming. But remember, take heart in the fact that if I ask you about any of these veins and arteries, for the most part, they will be multiple choice questions. So all you have to do is memorize these veins and arteries well enough that you can recognize them on a list of possible arteries. Some of them I will ask you to name outright, and that's usually the way we differentiate really good students from average students. So we'll do the best we can. When I was a university student, undergrad, I didn't get straight A's because I was not a terribly gifted student. That doesn't mean you can't have a good career as an academic or as anything else. So don't be discouraged if you're finding this difficult. As I've said many times, it's meant to be a bit difficult. In this particular course, I try to design this course so that it's very difficult to fail, but it's also very difficult to get an A. And everybody else is somewhere in between an F and an A. Everyone is somewhere between the D and the B plus is where most people will be. Very few people generally fail this course. Very few people fail the course, but also very few people get A's. And that's usually the way people try to design courses because it allows us to differentiate different types of students. All right, so just moving on to the blood vessels and the circulation of blood vessels. So as an overview, I'm going to tell you the physical differences between arteries and veins. Some of the things like, for example, the fact that veins have valves to prevent blood from flowing in the wrong direction because the blood pressure tends to be quite low in the veins, whereas arteries do not have valves because there's not much danger of blood flowing in the wrong direction through an artery because it's traveling at fairly high pressure. But after the blood has traveled through capillaries, it loses a lot of its speed and pressure, and therefore it is in danger of either stagnating meaning to stay in the same place, or flowing backwards. So you have veins have valves in order to prevent that. And as I said in the last lecture, we'll also discuss the physical properties of capillaries, which are the blood vessels that are specifically intended to deliver oxygen to the organs of the body. So they have very thin walls as opposed to veins and arteries, which have very thick walls. We will learn about different types of blood pressure. We touched on that briefly in the last lecture. We will again talk about ways to regulate blood pressure, how to make blood pressure, things that make blood pressure go up or down. We talked about that briefly last time as well. We will briefly mention the lymphatic system, which acts in this case in the context of blood and circulatory system. The lymphatic system acts as a backup drainage system that prevents swelling when too much of the serum leaks out of the capillaries into the surrounding tissue to cause swelling. So that swelling is reversed by the lymphatic system. Then we'll talk about anaphylactic shock, which is what happens when you have the capillaries in the body become extremely leaky, and you might lose 50% of your serum out into the tissues, which will cause a dramatic drop in blood pressure, which may cause you to faint or even possibly die because your heart is not getting enough oxygen because the blood pressure has dropped and the speed and the pressure of the blood have dropped. So it's difficult for the blood to get around the body and supply all the organs with enough oxygen. Many of the organs can tolerate a lack of oxygen for a little while, but the brain and the heart generally can't. They need lots of oxygen, especially the brain. So anaphylactic shock is where you have a sudden drop in blood pressure because of a sudden leakiness of the capillaries. And it's often caused, more often than not, it's caused by an extreme allergic reaction to something. You may know somebody who's allergic to bee stings and they carry something called an EpiPen. The EpiPen contains epinephrine. which is a way of increasing the blood pressure. So if they go into anaphylactic shock because they were stung by a bee, you as their friend can jab them with a syringe full of epinephrine to bring their heart rate up enough, to bring their blood pressure up enough that they can survive the shock. Okay, we will also spend a very brief amount of time talking about blood usage around the body and how the blood usage around the body differs depending on whether you're resting or exercising. One of the key takeaway messages from that is that regardless of whether you're exercising or resting, your brain uses the same amount of blood, which is kind of unusual. It's like the body is designed, as I mentioned to you before, I don't really believe in intelligent design, but the body has certainly adopted or evolved so that the brain is the last organ to be deprived of blood. The blood, no matter what's going on with your body, enough blood is always being diverted to your brain to keep your brain functioning properly, because the brain is very sensitive to being deprived of oxygen. Okay, so we'll discuss that when we get to the blood usage part. And then we're going to spend it's boring to you, but it's exciting to me, a boring section of the lecture talking about and learning the names of the important blood vessels that supply blood to different parts of the body. And then we'll talk about a profession that you can go into called phlebotomy. The word phlegm is an old Latin word meaning the blood. And so a phlebotomist is somebody who basically takes blood samples, right? So I'm sure you've been in the hospital where somebody took a blood sample, or you might have been in the hospital where you might have gone to a clinic where somebody takes a blood sample. The people who took your blood samples were probably not nurses or doctors, even though doctors and nurses are trained to do that. It makes more sense that because there's such a need for blood samples when you're in a medical setting, there's such a need for blood samples that it doesn't make sense to hire somebody who's trained to do all kinds of things and then have them spend all day just taking blood samples. It's better to simply train a technician who does nothing but takes blood samples. And so that's one of you can become certified as a phlebotomy technician in a few weeks, in fact. So it's, as an allied health profession, being a phlebotomist is one of the quickest things that you can become certified in, and you can immediately start working in a hospital if you can find a job. But you can't work in a hospital as a phlebotomist if you don't have the certificate. But not that many people have the certificate, so somebody with a Bachelor of Science degree who does not have a phlebotomy certificate cannot do that job because it's illegal. You have to be certified. But if you just have an AD degree from Columbia College and then you go and spend 5 weeks at BCIT or 5 weeks at Thompson Rivers University, where they teach phlebotomy as well, you can get certified, and then you can go to work in a hospital if they have a vacancy. All right, and then at the end we'll talk about blood vessel pathologies, problems that occur with blood vessels, as we usually do. All right, so there are 5 different types of blood vessels in the body. There are arteries, which, as we defined before, they take blood away from the heart at high pressure. Those arteries divide up into smaller arteries that are called arterioles. The arterioles eventually empty their contents into networks of very small blood vessels with very thin walls that are called capillaries. As I said before, the purpose of the capillaries is to deliver the oxygen to the organs of the body. So that's why they have the thin walls, to allow the oxygen to diffuse across the capillary wall. And then when the blood is oxygen depleted, it has to get back to the heart. So the capillaries empty their contents into small veins called venules, and those venules will eventually combine into larger venules called veins. And then the two largest veins in the body, as we mentioned before, the 2 largest veins in the body are the superior vena cava and the inferior vena cava, which take blood directly back to the right atrium. Okay, so once again, arteries carry blood away from the body, away from the heart at high pressure, and lead into arterioles. The arterioles carry blood at slightly lower pressure, and they empty their contents into capillaries. The capillaries are networks of microscopic blood vessels that are barely barely the size of one erythrocyte. An erythrocyte, remember that an erythrocyte is a red blood corpuscle. A red blood cell is called an erythrocyte. And the capillaries are so thin that they basically let the erythrocytes go through them in single file. So they are very thin, but there are lots of them. These networks are very extensive of capillaries. So capillaries are not really visible to the naked eye. You need a microscope to see the individual capillaries, but they are extensive. They're everywhere, and so they're small, but there's so many of them that they're responsible at any given time. Most of the blood in the body is to be found in capillaries, not veins or arteries. Okay, so once the oxygen has been deposited to the organs, the blood leaves the capillaries into small veins called venules, and then into large veins, and then back to the heart. Now there are some physical differences between arteries and veins. Okay, but first of all, let's notice that in these two cross sections, these two diagrams of arteries and veins, notice that they all have the same three. They are all made of the same three layers of tissue. So veins and arteries are both made of three layers. The outermost layer is made of connective tissue. Below the outermost layer, we have a layer of smooth muscle, which is used for vasodilation and vasoconstriction. It allows the blood vessel to get narrower or to get wider, to dilate and get wider, or to get narrower, to constrict. So vasodilation, vasoconstriction, that function is carried out by the layer of smooth muscle that's in the middle here. And then in the very deepest layer, we have a layer of simple squamous epithelium, which, as you already know, we give it a special name. We call it endothelium when we find it inside a blood vessel. Okay, so arteries and veins both have the same three layers of tissue. They're both made of the same three layer. And then, by the way, the open space on the inside of the blood vessel that the blood flows through is called the lumen. You may recall from the lecture on cell biology that anytime you have an empty space, it's called, the generic term for an empty space or the inside of an empty vessel is called the lumen. So the very inner part of the blood vessel where the blood is flowing is referred to as the lumen of the blood vessel. All right, so notice now that in the artery, the layer of connective tissue is quite thick. And that is because the blood is traveling through the arteries at very high pressure, and so you need this thick, strong layer of fibrous connective tissue in order to reinforce the strength of the artery. Notice in the vein it's quite thin, and that's because it doesn't need to be any thicker, because when the blood gets to the veins, it's traveling at low velocity, low speed, and low pressure. Another difference is that the veins have valves to make sure that the blood flows in the right direction, because the blood is traveling so slowly through many of the veins that if left to its own devices, it would just stop, or it would actually end up flowing backwards. And so we have valves in the veins to prevent backflow of blood in the wrong direction. So if I asked you to tell me two physical differences, or at least two physical differences, or different properties between veins and arteries, you can say that the arteries have a thicker layer of connective tissue than the veins do, and you would say that the veins have valves to prevent backflow, which arteries do not. Okay, then in the middle here, we're showing that the artery empties into an arteriole. The arteriole then empties into a capillary network. Notice that the capillary network looks like kind of like a fishing net. It's a kind of a redundant network of little tiny blood vessels that have very thin walls, and they are interconnected at many spots. And so if any one of these capillaries is blocked, the blood will simply flow around the blockage and get to the organs another way. And this picture in the bottom is actually a bright field microscope image showing red blood cells, or erythrocytes, inside a capillary. And you can see that it's basically just wide enough to allow the red blood cells to travel through in single file. And so that would be, do you remember from the introductory lecture, approximately how big a human cell is? Approximately how big is an erythrocyte? An erythrocyte is slightly smaller than the average human cell. An erythrocyte is around 7 microns, around 7 micrometers. All right, so capillaries, by extension, capillaries are 7 or 8 or 9 or 10 microns in diameter, which is very thin. Okay, now this is a histology slide, and from looking at the histology slide, you can tell, first of all, that this is an artery down here because it has a very thick layer of, it has a thick layer of connective tissue on the outside, a relatively thick layer of smooth muscle next, and then you have the endothelium, and then you have the lumen in the middle. And the lumen, because the artery is made of these strong materials, it remains round even when you cut it with you cut it into a slice with a machine called a microtome that slices the tissue, and it remains, it remains kind of this round shape. Now, when you cut up tissues into slices, veins are weaker and they tend to get squished when you cut them in this machine called a microtome, and that's why a vein usually ends up looking like this. But from this vein, you can see that there's a thinner layer of connective tissue on the outside, a thinner layer of smooth muscle, and then you have the thin layer of the endothelium, and then the lumen of the vein is kind of crushed in this case. This particular vein has a larger diameter for its lumen than the artery does, but it's carrying blood at a slower rate, so it ends up being a give or take thing. And here's another bright field microscope image showing the erythrocytes traveling through the capillary in single file. All right, so we just learned that all of the blood vessels have the same 3 layers. They just 3 layers of tissues. They just differ in thickness, right? So the technical name for these 3 layers, I just told you what they're made of. But the technical terms for these layers of tissue are as follows. Okay, so the inner layer that surrounds the lumen, we call it the endothelium, but the tissue, the name of the tissue is the endothelium, and then the layer of that tissue itself is referred to as the tunica intima. Tunica is the Latin word for a shirt. And so the word tunica intima, intimate means close to, very close to. So tunica intima means, literally translates as an undershirt, right? So it's the inner layer, the inner shirt of the blood vessel. So the endothelium, the tunica intima is made of endothelium, and that of course is just simple squamous epithelium. Then in the middle, the smooth muscle, we give it the name tunica media, meaning the shirt, the middle shirt, right? The middle tunic, right? And then that's responsible for vasoconstriction and vasodilation. And then the outer layer is the tunica externa, which literally translates as the outer shirt, or the coat on the outside, is what's made of fibrous connective tissue. That layer is absent in capillaries, right? So we have the tunica intima, tunica media, and tunica externa going from inside to outside. Okay, once again, here's showing the tunica externa on the outside, tunica media in the middle, and tunica intima on the inside. Right. And so you can see those 3 tissues there, right? So the tunica, if I asked you what is the tunica intima of a blood vessel made of, you can say endothelium. And then you can put in brackets, you could write in brackets, if it was a short answer question, you could say that that is made of squamous cell epithelium, simple squamous cell epithelium. All right, what about the arteries? So as we said, they carry blood away from the heart and they lead into arterioles. They generally have the thickest walls. The thickest part, of course, is the tunica externa, that's made of a thick layer of connective tissue that gives it extra strength because it's carrying blood at high pressure. And we learned in last lecture that the example of an artery is the aorta. The aorta is the blood vessel that leaves the left ventricle, so the blood is traveling directly from the left ventricle into the aorta. The aorta is an example of an artery, and it just happens to be the largest and strongest artery in the body that is carrying blood at the highest pressure. So that's the aorta. Now, one interesting thing about the arteries is that there are two types of arteries. One type is classified as an elastic artery, and the other is classified as a muscular artery. The elastic arteries have, in the connective tissue, they have a lot of elastin protein, which makes them elastic and stretchable. And that's necessary if you have an artery that's so strong and is carrying blood at such high pressure that it actually has to be able to stretch a little bit. And really the only artery that we have to worry about that's an elastic artery is the aorta. Okay, all the other ones are basically muscular arteries that they're not really stretchable, right? So they're muscular rather than elastic. Okay, so this is just showing you on the left, this would be a cross section, a transverse section through the aorta, and it has a lot of elastin in the muscle fibers and the connective tissue as well, versus a muscular artery as seen on the right. I do not, by the way, I do not expect you to be able to differentiate between an elastic versus a muscular artery. Okay, now arterioles carry blood from the arteries into the capillaries. They're smaller and they have a pulse, and they do not have valves. Capillaries are microscopic blood vessels that bring oxygen to the organs. They have generally only about one red blood cell, one erythrocyte in diameter. They have very thin walls and reduced or absent smooth muscle and reduced or absent connective tissue. Oxygen will diffuse. It allows oxygen to diffuse across this layer, thin layer of tissue, and then so oxygen gets into the organs, and then carbon dioxide and ammonia and other waste products will go back into the capillaries. So this is a way of exchanging the good stuff for the garbage. Right. So, by the way, allowing oxygen to get into the organs is referred to as perfusion. Perfusion is a technical word. We'll talk more about perfusion when we get to the respiratory section of the course. Okay, and then blood, by the way, blood travels the slowest through the capillaries. Of all the blood vessels in the body, the arteries and the veins are not meant for perfusion. They're meant to get blood from one part of the body to another as quickly as possible. Right? So blood travels very quickly through arteries. It travels relatively quickly through veins, and it travels very slowly through capillaries, right? So capillaries, if I ask you where in which type of blood vessels does the blood travel the slowest, you would say the capillaries, and where does it travel the fastest? That would be the arteries, of course. Okay, now here's an interesting thing. The autonomic nervous system is able to control little tiny muscles that control entry to the different capillaries throughout the body, and those little valves that allow blood to go into or stay out of the capillary are referred to as precapillary sphincters. A sphincter is a little ring of muscle that it either opens up or closes off the end of a little duct. So in this case, we have these little rings of muscle that close off entry into the capillaries throughout the body, and your autonomic nervous system is able to divert blood from one part of the body to another where needed because of its control over these precapillary sphincters. So we mentioned during the endocrine section of the course that when you have the fight or flight response, the sympathetic division of the autonomic nervous system is activated, and so blood is diverted away from your digestive organs and away from your skin and over towards the lungs, the heart, and the arm and leg muscles in case you have to fight or run away. Right? So the only way the body is able to do that is by closing off the precapillary sphincters that take blood to the digestive organs, closing off the precapillary sphincters that take blood to the skin, and then opening as wide as possible the precapillary sphincters that deliver the blood to the muscles. So this is controlled by precapillary sphincters. Okay, so here we see a close-up of the capillaries, and you can see the blood is freely flowing through the entire capillary network on the top picture, the top illustration. And in the bottom illustration, the body, for whatever reason, has decided to bypass this particular capillary and closes off. It has closed off all of these precapillary sphincters, so the blood flows directly from this artery into the vein so it can go elsewhere. It can be used elsewhere. And as I said, it's a these capillaries are networks because they look a bit like a net. You know, you can see that there are many ways for the blood to travel through a network. If one of the little capillaries is blocked, the blood can flow around it. So these things, if you look at them under a microscope, they kind of look like a fishing net that's made of many interlocking small tubes. So on the top left, we have a bright field microscope image showing the erythrocytes traveling through the capillary in single file. On the bottom right, we have a what's known as a false color scanning electron microscope image, where they took a picture with the scanning electron microscope of the capillary there, and then they colored the red blood cells inside it red, so you can see where they are, and you can see the capillary that's encasing them. The other things, the round things that are surrounding that capillary in that image, are adipose cells. So it's loosely packed tissue, tissue that has room for liquid in between cells. So if you have, you know, there are some parts of the body where the cells are joined together very tightly, like in your skin. And there's some areas in the body where the cells are held together very loosely, like in the adipose tissue, and they have space available in between cells to let fluid in, and you call that interstitial spaces. You call the spaces between cells interstitial spaces, and they can either fill up with fluid or drain fluid. If they fill up with fluid, you have swelling. If it drains, the swelling goes away. All right, now we give the capillaries different names depending on how leaky they are. Some capillaries are leaky all the time, some capillaries are only leaky some of the time, some capillaries are not very leaky at all. Okay, so a continuous capillaries, they are made of, they usually don't leak unless you have an allergic reaction that causes them to be leaky. So when we talk about the lymphatic system later on, we're going to talk about the fact that if your body is allergic to something, like pollen, for instance, if you have hay fever, certain cells release a chemical called histamine that has the effect of making the capillaries leaky, and that allows fluid to leak out of the capillaries into the soft tissues of the body, including the soft tissues around your eyes and your nose. And that's why you have if you have hay fever, you get these puffy eyes and a red puffy eyes, because the blood, the entire blood, is literally leaking out of the capillaries that surround the soft tissues of your eyes and your nose. Okay, so continuous capillaries are not meant to be leaky. They rarely leak serum out into the surrounding tissue. Fenestrated capillaries have holes in them which are called fenestrations. Right, so fenestrated capillaries have holes called fenestrations, and they are leaky. And then the leakiest of all are the sinusoid capillaries, which actually have an incomplete endothelium, so that they leak like a sieve all the time. Right? They're basically not even whole, right? So they're meant to leak all the time. Okay, so over here on the left, you can see a continuous capillary, and there are no holes in it, but the cells that make up this capillary will kind of contract and leave gaps in between them if they're stimulated to do so by histamine, for instance. And then over here we have, in the middle, we have a fenestrated capillary with fenestrations, and it's fairly leaky most of the time. And then over here we have a sinusoid capillary that has gigantic holes in it at all times, and so it's fairly leaky at all times, right? So we have some capillaries that can only become leaky when they're ordered to do so. We have some that are a little bit leaky all the time, and we have others that are very leaky all the time. Okay, so now the venules, they take blood from the capillaries to the veins, and then the veins carry the blood back to the heart. They carry it at low pressure. You cannot feel the pulse in a vein. In fact, so you know that the blood is flowing through the arteries in a kind of a pumping action as the heart beats during the systole of the heart. But once the blood enters the capillaries, it slows down, and then when it enters the venules, it's still traveling slowly, and the pulse has dissipated. The pulse has disappeared. It is dissipated. Right? So that's why veins have valves, because the blood is flowing very slowly. The flow of blood back to the heart is referred to as venous return. Venous return. So if you talk about somebody having poor venous return, it means that they have low blood pressure, low pressure, very low pressure in the veins, which makes it difficult for the blood to get back to the heart. If the blood doesn't move, if it sits in the same place because the blood pressure is so low in the veins and because you have poor venous return, if that happens and the blood sits still for a long time, it will form clots. Right? And so that it will form clots that block the veins, the deep veins of the body. Remember, the superficial veins are the veins that are close to the surface, and then the deep veins are the ones that are buried underneath layers of tissue and muscle deep in the body. And if you have poor venous return, meaning that the blood is having a hard time getting back to where it came from and it sits in the same place for a long time, it forms clots. Those clots are called thrombi. So then you have something called deep vein thrombosis, which we'll talk about later. Okay, so the veins, no pulse, blood is traveling at low pressure and low speed. Okay, now the fact that the blood is having a hard time getting back to the heart as it travels through veins, and it has valves to assist this. The other thing to know about the veins is that the muscles, constriction of the muscles is actually useful to help the blood flow through the veins. Right? So if you take a look at this diagram here, we have a vein and it has two valves that are pointing in the same direction. So if not for these two valves, if you squeezed this vein in the middle, the blood would flow in both directions, wouldn't it? But because we have two valves, when you squeeze this blood vessel, this vein, the blood will only go that way. It will only go up in our diagram, right? So the valves make the blood go in the right direction, and it's actually the muscles that are responsible for squeezing them. So if your blood doesn't circulate well, this is a common problem with elderly. You should be the elderly, in order to assist venous return, they should get up and walk around, get up and move around as much as possible, use your muscles, and then the contraction, the squeezing of the muscles helps to squeeze the veins and move the blood around. So you circulate the blood by movement. So I've said this before, and it's an obvious point, that as you grow older, you should make an effort to be as active as possible, because if you're not active, you lose mobility, you lose function, and then it's very difficult to get it back if you try and get it back later. But if you exercise regularly, especially as you get into older age, then you will end up losing less of your mobility and less of your bodily functions to begin with, which is the best way to do it. So venous return is assisted by muscle contraction. So getting up and moving around and moving your arms and legs helps the blood to circulate and prevents thrombosis, deep vein thrombosis and things like that. Okay, now what about all these different types of blood vessels? How much of the blood is contained in the body at any given time in capillaries versus veins versus arteries? Right? At any given time, most of the blood in the body is flowing through the capillaries. Right? Blood travels at high velocity through the arteries. The capillaries act as kind of a damper, which slows down the blood and eliminates the pulse. The pulse will dissipate. And then when the blood comes out the other side of the capillary and travels through veins, it's traveling as a kind of a weak, continuous flow without a pulse. This diagram illustrates several things. This little illustration up here at the top is not drawn to scale, but what it's showing you is that blood flows through arteries into arterioles and then into capillaries in the middle here and then out to venules and veins. These capillaries are not to scale. In fact, if you look at the amount of if you add up all the area in the body that's taken up by arteries versus veins versus capillaries, you'll see that most of the area of the blood vessels in the body is taken up by capillaries. And by the same token, the majority of the most blood in the body at any given time is flowing through capillaries, not arteries and veins. All right, now what is the velocity of the blood traveling through these vessels? Obviously, the blood travels fastest through the arteries, and then slightly slower through the arterioles, and then it slows down to a crawl as it travels through the capillaries, and then it starts to speed up a little bit as it gets back into the veins, partly because of muscle contraction and movement and the veins being squeezed by the muscles. Okay, and then here you notice that you can see a pulse, you can feel a pulse as blood travels through the arteries. The pulse dissipates as it travels through the capillaries, which act as kind of a shock absorber or a damper. And then by the time the blood gets out to the veins, there's no pulse at all. Okay, we've mentioned this in the last lecture. There are two types of blood pressure. One of them is the real physical blood pressure, which is called the hydrostatic pressure. It's the real physical blood pressure. Now, the interesting thing is that when blood enters the capillary, it has the highest hydrostatic pressure on the arterial side of the capillary. Okay, I'll show you what that means in a minute, so don't worry too much yet. Okay, the oncotic pressure refers to the osmotic potential of the blood. So how salty is the blood? And remember that we have a protein called albumin that contributes to the tonicity of the blood. So if the liver produces a lot of albumin and you have a lot of salt in your blood, that will encourage fluid to leak into the capillaries rather than out of the capillaries. So if the blood is hypertonic relative to the surrounding tissue, then water will diffuse through osmosis, will diffuse into the capillary and increase the blood volume. Right. So what happens is, I'll show you a picture. I'll show you what happens here in a picture. Okay, so here on the left side we have the arterial side of the capillary, and on the right side we have the venule side of the capillary. So when blood enters the capillary from the arteriole, it has the highest hydrostatic pressure, and it actually pushes some of the serum out of the capillary into the soft tissues, into the tissues that are surrounding the capillary. So liquid, the blood actually loses volume as the serum, the blood serum, the blood liquid portion is being physically pushed out by high hydrostatic pressure on the arterial side of the capillary. And when you push a fluid through some kind of a membrane using pressure, that's called filtration, isn't it? So that's why we have filtration up here. Right. Now, as you get to the middle of the capillary, the serum doesn't leak, neither leaks in nor leaks out, because the oncotic and the hydrostatic pressures are roughly equal. And then when we get way over to the venule side of the capillary, the hydrostatic pressure has diminished because we're farther away now from the venule. And when you get to the venule side of the capillary, you get reabsorption of some of that fluid that you lost over here, because the oncotic pressure of the blood at this point is greater than the hydrostatic. The oncotic pressure to pull fluid back into the blood is now greater than the hydrostatic pressure to push it out. And so ideally there would be no net gain or loss of liquid in the capillary blood. In fact, that's an ideal situation. It doesn't really happen that way. In fact, what happens is a little bit more fluid always leaks out than you get back, and so we need a backup system to drain away that excess fluid, and the lymphatic system supplies that backup system. Okay, this is just another diagram showing the same thing. It shows you that the hydrostatic pressure of the blood is highest on the arterial side, and then the hydrostatic pressure becomes less and less and less as we get over to the venule side, and eventually it gets to a point where the oncotic pressure, which is shown in blue, the oncotic pressure encourages the fluid to drain back into the capillary. So theoretically, there should be no net gain or loss of fluid from the capillaries, but in reality, the hydrostatic pressure tends to be a little bit higher than it should be, and so some of the fluid leaks out, and then you would get swelling if not for the lymphatic system. Okay, we touched on this in the last lecture, the fact that you can vary the blood pressure in 3 ways. Usually at the same time. This is usually happening at the same time. So if you increase the heart rate, you will increase the blood pressure. If you decrease the heart rate, you'll decrease the blood pressure. Easy. Right? The other way you can do it is by varying the diameter. Right? So that is a function that's controlled by the autonomic nervous system. So if you constrict the blood vessels, the blood pressure goes up, vasoconstriction. If you open up and increase the diameter of the blood vessels, that's called vasodilation, and that causes the blood pressure to go down. Okay, the third method is that you can vary the blood volume. If you increase the blood volume, that tends to make blood pressure go up. If you decrease the volume, that makes blood pressure go down. And the amount of fluid that is in the blood is determined by 2 things. Number one, it's determined by the renal system, the kidneys. And what happens is that the kidneys decide how much water it's going to keep versus how much water is it going to let out in the urine. Right? So if the kidney decides to keep a lot of the water, then you end up retaining water. The blood volume goes up and you have higher blood pressure. That's why if you eat a lot of salt, the kidneys tend to retain water, and you carry a lot of water, which makes your blood pressure go up, which is not a good thing. So we'll talk about how that happens when we get to the renal section of the course. But the other way that you can control it is by having the liver produce more or less serum albumin, which will vary the oncotic pressure of the blood, so that if the blood is hypotonic relative to the tissues, the fluid will leak out of the capillary and the blood volume will go down and the blood pressure will go down. On the other hand, if the blood is hypertonic relative to the surrounding tissues, the water will leak into the capillaries and increase the blood volume and increase the blood pressure. Okay, so we have 3 different methods: varying the heart rate, varying the diameter of the blood vessel, and varying the blood volume. And then varying the blood volume can be divided into 2 parts as well. Number 1 is how much water do you retain at the kidneys, and number 2 is how much water seeps into the capillaries due to oncotic pressure. And so those 4 things in total will control the blood pressure. All 4 of those things are operating simultaneously. It's very difficult to juggle 4 things at once. When you're young and healthy, those 4 systems are in perfect alignment and you tend not to have high blood pressure or low blood pressure. But as you get older, those systems start to get unsynchronized, and then you end up, most older people tend to have chronic hypertension. Remember, the term hypertension means chronic high blood pressure. So chronic means long-term, acute means short-term. Chronic hypertension means that you have perpetually high blood pressure. And it's a result of these systems losing their balance with one another. Okay, so usually we end up losing a little bit more serum, a little bit more water out of the capillaries than we get back, which causes a little bit of swelling. The technical term for swelling is edema. The technical term for swelling is edema. Now, luckily, that would lead to edema if not for the lymphatic system, which consists of lymphatic vessels. Right, so you know that we have a network of blood vessels that carry blood around the body. There's another network of small tubes that travel around the body called the lymphatic vessels. They're part of the lymphatic system. And those tubes are filled with basically serum that leaked out of the blood in the soft tissues and then got sucked back in to the lymphatic system to drain away the excess drainage. Okay, on the top here, these images, we have edema. The one on the left is referred to as pitting edema, because if you stick your finger or your thumb into the swollen tissue and then you remove it, you leave a pit, right? So that's pitting edema. You can see here that somebody's feet swell up because gravity is working against venous return. Right, so what happens is, you notice that many elderly people, if they stand still for a long time without moving around, their feet will swell up. Or if you sit down for a long time, your feet will swell up. And the reason for that is because your heart is not as strong as it used to be. So the blood pressure in certain parts of the body, the return blood pressure is lower. Generally, the arterial blood pressure is higher, but the venous return is lower. The venous return is faulty. And so what happens is, when blood is flowing down to your feet, it easily gets down to your feet because it's going with gravity. On the way back, your blood has to flow against gravity, and so it's having a harder time getting back. So the blood goes down to your feet faster than it comes back up again. So if the blood is going down to your feet faster than it's coming back up, that has the result of increasing the local blood pressure at the very bottom of your feet. At the bottom, you just imagine a U-bend pipe where the water is getting down to the bottom of the pipe faster than it's getting back up. The pressure will be the greatest at the bottom of that tube. And that's exactly what happens. So you tend to have high hydrostatic blood pressure in the capillaries in your feet because the blood is getting down to your feet with the help of gravity, but it's having a hard time getting back up from your feet because of it's working against gravity. All right, this is a diagram of the lymphatic system. You can see all of these green tubes that are flowing around the body. Those are lymphatic vessels. Here we have a diagram that shows an arteriole, a venule, a capillary in between, a whole bunch of adipose tissue, loosely packed cells that have interstitial spaces that can be filled with fluid. And then when you have fluid being forced leaking out of the capillaries, it could lead to edema, swelling, except that the excess fluid is drained away by this network of lymphatic vessels here. Right, so here we have a lymphatic vessel, a lymph vessel that's draining away the excess fluid that leaked out of that capillary. All right, so the lymphatic system is part of the immune system, but one of its functions, in addition to being part of the immune system, its function is to drain away excess fluid from interstitial spaces. Interstitial spaces, these are the spaces between cells. And what happens if you don't have the lymphatic system? What happens if something clogs the lymphatic system? Well, the effects of clogging the lymphatic system can be very dramatic. And I'm going to show you some slightly disturbing photographs, so brace yourself if you don't want to look. But if you block the lymphatic vessels, one of the ways you can block the lymphatic vessels is with a microscopic parasitic worm called Wuchereria bancrofti, which causes a disease called elephantiasis. And this little worm called Wuchereria bancrofti is just the right diameter to block the lymphatic vessels and prevent the lymphatic vessels from draining away this excess swelling. And so you get runaway swelling until your arms or your legs are swollen up so much that they look like an elephant trunk. Okay, so let's have a look. Okay, so lymphatic vessels become blocked with a disease called elephantiasis. Elephantiasis is caused by a microscopic parasite, a parasitic worm called Wuchereria bancrofti. If I ask you about Wuchereria bancrofti, it will be a multiple choice question, but I probably won't. Okay, so elephantiasis caused by Wuchereria bancrofti. You might have seen the movie The Elephant Man, which was about a man called John Merrick who they believed had elephantiasis around in the 19th century. He was basically a spectacle, right? He was this is a barbaric age. We're still living in barbaric ages, in my opinion, but we're not as bad as we used to be. And in the 19th century, the only way this poor man could make a living was by being what's called a circus freak. People would pay money to see him and his deformities, and he was called the Elephant Man. And in fact, we now believe that he didn't have elephantiasis. He had another disease called Proteus syndrome. Right, so this, if you look at his face, it's not swollen. This is not swelling. This is excess growth of tissues. But the Elephant Man made the disease elephantiasis famous. But there are lots of people who really did have elephantiasis, including some people in the 19th century who were also, swollen up like this. So I'm going to show you a disturbing picture of actual elephantiasis. So this woman also worked in the carnivals, and she was called the Elephant Woman. And so you can see this very distorted, sad situation where these microscopic worms have blocked the blood vessels, causing the legs to swell up until they look like an elephant trunk. Right? So the effects of blocking the lymphatic system are actually very dramatic. It's very dramatic and dangerous what happens if the lymphatic system is not able to drain away swelling. Okay, so swelling is where you have edema is where you have swelling. I mentioned the fact that you can have swollen feet because the blood it's easier for the blood to get down to the bottom of your feet because gravity is working with it as opposed to coming back up. Okay, anaphylaxis is where you have, if you have an allergy, like a peanut allergy, or you're allergic to bee stings, your body has an extreme allergic reaction, a very sudden extreme allergic reaction, which causes severe sudden swelling. The swelling is caused by the capillaries suddenly becoming leaky, and all of the serum and many of the blood cells leak out of the capillaries into the soft tissues that surround them, and you get swollen body parts. Looks like this. Right, so you can see the soft tissues around the eyes have swollen the eyes shut. Right, this is an anaphylactic reaction. Now, you have a rapid, because you've lost so much fluid from the capillaries, you also have a rapid sudden drop in blood pressure. That means that the blood can't circulate around the body as easily because we already said that if you increase the blood volume, you increase the blood pressure. It stands to reason, therefore, that if you decrease the blood volume, you will decrease the blood pressure. So the blood pressure will drop dramatically in anaphylaxis. And so it's difficult at such low blood pressure. It's difficult for the blood to travel around the body quickly. So organs like your brain and your heart are suddenly starved for oxygen. You'll probably faint and fall on the floor. Once you're on the floor, you might wake up because suddenly, when you're standing up, your heart has to pump blood up to your head against gravity. If you're on the floor, your head and your heart are at the same level. They're next to each other, basically. And then it's easier for the heart to pump blood to your brain. So people sometimes, when they have an anaphylactic reaction, they faint and then they wake up when they're on the floor. Right? But this is generally a bad situation because you might have a heart attack. Okay, so if you know anybody that is allergic to peanuts or nuts or bee stings or anything like that, they have a severe allergy problem. They're in danger of going into anaphylactic shock if they accidentally eat a peanut or if they accidentally get stung by a bee. And so they carry something called an EpiPen. That's what this is. And either they or you, as their friend, are supposed to take that out and jab it into their thigh. And that EpiPen contains a spring-loaded syringe, a spring-loaded needle that gives them a shot of epinephrine. Remember from the endocrinology section that epinephrine increases the heart rate. Increasing the heart rate will increase the blood pressure, and that will, allow the blood to circulate around the body as a temporary emergency measure, allow the blood to circulate around the body fast enough that they can be rescued until medical people get there. Okay, so this is called an EpiPen because it's full of epinephrine. Okay, so anaphylactic shock, you have a sudden violent immune reaction. It's called a hypersensitivity reaction, by the way. And this causes the capillaries to become very leaky. Somebody's allergic to bee stings or peanuts, for instance. The blood serum leaks out into the interstitial spaces and causes rapid swelling. It may even cut off swelling it may even cut off breathing if the throat swells up, so that's not good. Causes a rapid drop in blood pressure, which may make you faint, and it might even cause a heart attack. So as an emergency measure, you have to raise the blood pressure quickly, and the fastest way to do that is to increase the heart rate. And so you stick somebody with an EpiPen, you give them a rapid shot of epinephrine. Okay, we learned in the last section how to measure blood pressure using a sphygmomanometer. So you take the sphygmomanometer and you put it over the brachial artery, and then you put a stethoscope just below the sphygmomanometer in the crook of the elbow so you can listen to the blood in the brachial artery. Then you inflate the blood pressure cuff until you can. So at the beginning, you won't hear any Korotkoff sounds. You will not hear any thumping of the blood against the artery wall because the pressure is too low. As soon as you start to inflate the sphygmomanometer cuff, you'll start to hear these sounds called the Korotkoff sounds, thump, 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 right? And then as you continue to inflate the cuff, you'll actually succeed in cutting off the blood flow altogether in the brachial artery. And then what you do is you release the pressure slowly until you hear the Korotkoff sounds again. And when you just hear them again, you record that as the systolic pressure. For young, healthy adults, that is usually around 120 millimeters of mercury as measured on the sphygmomanometer. And then if you continue releasing it until you can't hear the Korotkoff sounds anymore, as soon as you stop hearing them, you record that as the diastolic pressure, which is usually around 70 millimeters of mercury. And then you report the blood pressure, the BP, as 120 over 70. You report the blood pressure as the ratio of the systolic pressure over the diastolic pressure. So there we are. We put the sphygmomanometer around the brachial artery. We put a stethoscope right below it so we can hear. We raise the pressure until we can't hear the Korotkoff sounds anymore. At that point, we've gone too far. So we start to release the pressure slowly. And when you just barely hear the Korotkoff sounds resume, you record that number, that pressure, as the systolic pressure. And then you continue to release the pressure until you stop hearing the Korotkoff sounds, and you record that as the diastolic pressure. So there's the sphygmomanometer, and then you put the diaphragm of the stethoscope just below the blood pressure cuff. And we mentioned in the last lecture that if you measure the blood pressure at the brachial artery and then the blood pressure at the ankle artery, then if you measure the ratio of the ankle blood pressure over the ankle systole over the brachial systole, you get something called the ankle brachial index. And if that ratio is less than 0.9, then you might have something called peripheral artery disease. Okay, what about the budget of blood around the body? Okay, so the normal person, when they're resting, they're generally pumping around 5 liters of blood per minute. We actually calculated it in the last lecture, presuming a cardiac output of, I won't go into that. But anyway, so when you're resting, there's around 5 liters of blood pressure traveling around the body. When you're exercising, there's maybe 15 or something in that area. Okay, so this is how blood is distributed depending on whether you're exercising or relaxing. So notice how during exercise, the percentage of the amount of blood that's sent to the muscles increases, as you'd expect. The amount of blood sent to the heart increases, as you would expect. Right? The amount of blood going to the skin increases as well, as you would expect, but why would you think that happens? Can you guess? Okay, so if you guessed that the purpose of that is to cool you off, you would be right. So as you exercise, your body burns more glucose. Burning glucose, converting glucose into ATP, any conversion of energy from one form into another results in a loss of some of that energy in the form of heat. So as you're exercising, your body is burning more glucose in the mitochondria. The mitochondria will generate heat, and then you have to lower your blood, due to homeostasis. You want to maintain your heat body temperature at around 37 degrees. So if the temperature goes up above 37 degrees, your body pumps blood to the skin surface so that you can sweat, and then the sweat will sublimate, and then when the sweat sublimates, it evaporates off your skin. That cools you off. Okay, now where do we still need, if we're exercising, do we still need all that blood running through our digestive system? And the answer is no. So the amount of blood when you're exercising, the amount of blood that goes to your digestive tract decreases, and the amount of blood that goes to your renal system decreases, the kidney and other parts of the body. But notice over here we have our friend the brain. Regardless of whether you're relaxing or exercising, the brain always gets the appropriate amount of blood because it's critical. Brain is a very important organ, and it's very sensitive to hypoxia, so it needs the same amount of blood no matter what you're doing. Okay, now for the unpleasant part. We're going to learn the names of important arteries and important veins. A new word that we have to learn is called anastomose. That's a verb. And an anastomosis is a noun. And an anastomosis is an interconnected network of blood vessels where it's kind of like a net, literally a net, where if there's a blockage, the blood can take another route to get around it, right? So there's some parts of the body where you have blood vessel A that leads directly into blood vessel B, and then blood vessel B bifurcates into blood vessels C and D, right? And so the blood is traveling in one direction only. And if you block one of those D or E blood vessels, the blood has nowhere else to get to the destination. But if there are many connections, kind of basically redundant connections between blood vessels, redundant connections, there are many ways for the blood to get to the same place, and that's called an anastomosis. And when blood vessels do that, you say that they anastomose. Right. Okay, so this is more common in veins than arteries, by the way, but we'll deal with that as we get to it. So this is an example of an anastomosis. These are the veins that you find on the inner surface the anterior surface of your arm, right? And if you became a phlebotomist, whose job it was to take blood samples, you would know all of these veins very well. So this is an anastomosis amongst arteries. For instance, inside the palm of your hand, you have this kind of circular structure called the deep palmar arch that sends blood down to the fingers, right? And so that's another example of an anastomosis. Okay, so anastomoses is the plural term. Okay, so remember that our arteries take blood away from the heart, and they take blood up to the head, down to the arms, and down to the legs. Right, so blood is flowing upwards through arteries to the head, it's flowing downwards to the arms and legs. Okay, so starting with the head, we have a left and a right common carotid artery, which travel up the neck to the brain. The common carotid artery bifurcates, each of the common carotid arteries bifurcates into an external carotid artery that sends blood to the face, basically, and an internal carotid artery that sends blood to the brain. The internal carotid arteries enter the skull through the carotid canals, the left and right carotid canals, and they deliver blood inside the cranial vault to the circle of Willis that delivers blood to the front part of the brain, the anterior side of the brain. And then we also have the left and the right vertebral arteries that travel up the back of the neck through the transverse vertebra, through the transverse foramina of the cervical vertebra. So you remember that one of the ways that you can tell a cervical vertebra from a thoracic vertebra or a lumbar vertebra is that the cervical vertebrae have holes in the transverse processes. And those holes are used for the vertebral arteries and the vertebral veins, which we'll talk about later. Okay, so the vertebral arteries, do you remember which hole they enter the brain, the skull through? Remember the left and right internal carotid arteries enter the skull through the carotid canal. Which hole does the left and right vertebral arteries enter the skull? They enter the skull through the foramen magnum along with the nerves that are traveling out of the brain. Okay, and they supply blood. The left and the right vertebral arteries supply blood to the basal artery, which distributes blood to the posterior side of the brain. In the thorax, you know that the aorta is the blood vessel, the artery that comes directly off the heart. And then as it travels upwards, we give it another name. We call it the ascending aorta, and then it bends over, call it the aortic arch, and then it Now coming off of the aortic arch is where we get the left and right carotid arteries, and also a set of arteries called the left and right subclavian arteries. And we'll talk about all of these again, so don't worry about trying to memorize these right now. So I'm going to discuss each of these arteries rather, in more detail. Okay, but basically the aorta comes off of the heart, it travels upwards, we call it the ascending aorta, it bends at the top, we call that the aortic arch, and then coming off of the aortic arch you have some projections, some smaller arteries that lead to the head and to the shoulders basically, and we'll talk about those. Right? And then what's left of the aorta bends and starts traveling downward, and we call that the thoracic aorta. And then eventually as we reach the diaphragm, remember that the diaphragm is the official boundary between the thorax and the abdomen. When we get to the diaphragm, there are some arteries that come off of the thoracic aorta that bring blood to the top of the diaphragm, and we call those the superior phrenic arteries. Remember the word phrenic refers to the diaphragm. So remember that the diaphragm is serviced by the phrenic nerves, and we had the phrenic nucleus, which is damaged in quadriplegics, for instance, which is what makes you a ventilator-dependent quadriplegic. Right. So the superior phrenic arteries are the little branches that come off of the thoracic aorta that supply the top of the diaphragm with blood. All right, looking at the arm, so traveling just underneath the clavicle, we have the subclavian artery. There's a left and a right subclavian artery. So the word subclavian literally means under the clavicle, underneath the clavicle. The subclavian artery is then renamed the axillary artery as it travels through the axillary area, the armpit, the pit of the arm. There's a little branch that comes off of the axillary artery called the humeral circumflex artery. Do you remember what circumflex means when we talked about the circumflex coronary artery? It means an artery it goes around in a circle basically. So on the shoulder, at the shoulder level, you have this little artery that kind of travels around and supplies blood to the deltoid muscle. So the humeral circumflex artery comes off of the axillary artery and supplies blood to the deltoid muscle. And then the axillary artery continues on and becomes the brachial artery, and then travels down farther down the arm to the radial and the ulnar, becomes the radial and the ulnar arteries. Remember, we measure blood pressure most commonly through the brachial artery. And then it heads into the deep palmar arch and the superficial palmar arch and the digital arteries. Each finger is a digit, and each finger has its own little artery called a digital artery. In the abdomen, we've got lots of other arteries to learn. So again, the diaphragm separates the abdomen from the thorax. Right? So we have this separates the thorax from the abdomen. So we have the diaphragm, and then so now as the thoracic artery travels through the diaphragm, we rename it on the other side. We rename it the celiac trunk, which is a very confusing name, but so the celiac trunk is the artery that's at the very top of the abdomen, right? So we have some blood vessels, we have some smaller arteries that come off of the celiac trunk that are supplying blood to the bottom of the diaphragm, bottom side of the diaphragm, and they are called the inferior phrenic arteries. And then we have the coming off of the celiac trunk, we rename it the abdominal artery. So as we travel farther down into the abdomen, we rename it the abdominal artery. And then coming off of the abdominal artery, we have a left and right renal arteries. Where do you think they go? Left and right renal arteries supply the kidneys, of course. We have a hepatic artery that supplies, what does the word hepatic mean? Of course, it means the liver. We have the gastric artery, which supplies the intestines. We have the splenic artery that supplies the spleen. Then there's a superior and inferior mesenteric artery. We'll talk about those later. And then we head down into the leg, where we have the abdominal artery bifurcates into the left and right common iliac arteries, which are here, that are traveling down to the legs. And then those arteries bifurcate again, and then you have the common external iliac artery that travels down into the leg and becomes the femoral artery. Okay, so heading down into the leg once again, we have the abdominal aorta, the abdominal aorta bifurcating into the left and right common iliac arteries, and then traveling down, becoming the external iliac artery, and then the femoral artery down the leg. Then the femoral artery kind of dips behind the knee, and we call it the popliteal artery. Then there's a couple of other arteries, the peroneal and the fibular artery, and the anterior and posterior tibial arteries that are associated with the fibula and the tibia. And then the lateral and medial plantar arteries, and then the dorsal pedis artery and the dorsal arch. The heart itself, of course, has lots of important arteries. So let's look at the area around the heart. Okay, so we have the aorta, which comes directly out of the left ventricle. Then we have the left and the right coronary arteries. Right, you remember that the left coronary artery bifurcates into the circumflex artery and the left ascending the LAD. Okay, and then as the aorta goes upward, it bends at the top, and it's called the aortic arch. Right, now, coming off of the aortic arch on the right side, we have an artery called the brachiocephalic trunk. Right, and then on the brachiocephalic trunk bifurcates into the right common carotid artery and the right subclavian artery. And on the left side, we don't have a brachiocephalic trunk. We just have the left. The left common carotid artery and the left subclavian artery coming directly off of the aortic arch. Right, so the heart, the blood vessels, the arteries that come off of the aorta are not symmetrical. They're not the same on the left as they are on the right, and I'll show you a picture of that in a minute. Okay. And then we have the left and right pulmonary arteries coming out of the heart, of course. They go to the left and right lungs. And then we have the blood traveling, then the aorta turns around and heads downwards towards the diaphragm, and we rename it, as it travels behind the heart, we rename it as the thoracic aorta. And then as it passes through the diaphragm, just underneath the diaphragm, we call it the celiac trunk. All right, so here's the picture. Take a look at the arch of the aorta. So on the left-hand side, we have two branches. One of them is the left common carotid artery, and the other one is the left subclavian artery. The subclavian artery travels laterally underneath the clavicle and then down the arm, right? So the arteries in the arm are derived from the subclavian arteries. Right? So at the aortic arch, we have the left common carotid artery and the left subclavian artery coming directly off of the aortic arch. On the right side, we don't do that directly. First, those two arteries are combined into a single artery called the brachiocephalic artery. Remember, brachio refers to the arm, and then cephalic refers to the head. So the subclavian artery is headed to the arm, and the cephalic artery is this is where you explain the cephalic part, right? So this is kind of interesting. So the brachiocephalic trunk bifurcates into the right common carotid artery and the right subclavian artery. Okay, now I was originally trained as a geneticist, and geneticists know that the human body is mostly symmetrical, meaning that we're the same. We have bilateral symmetry, which means that the right side is the same side as the left side most of the time, and that bilateral symmetry is controlled by a bunch of genes called homeotic genes. And I'm not going to ask you about homeotic genes in this course, but the reason why that's interesting is because here we have a part of the human body that's not symmetrical. So whenever a geneticist sees parts of the human body that are not symmetrical, and we start to wonder why, right? So we don't exactly know why this is true, but that's just the way that the heart develops. So these two arteries are separate on the left side, but they're initially combined on the right side, and then they split in two, they bifurcate. Okay, so this is what this is what the aorta looks like if you take the heart away. See, you remove the heart, and there you've got the aortic semilunar valve down there at the bottom. And then coming off the very end of it, we have the left and the right and the left coronary arteries. Okay, so here we have the ascending aorta heading up this way. And then we have the aortic arch, and then we have the thoracic aorta as it travels down this way. So we're just giving it a different name. It's the same artery. It's just we give it 3 different names if it's in 3 different places. Okay, what about the thorax and the abdomen? Okay, so the ascending aorta, as it ascends, it descends downwards. It becomes ascending is as when the aorta is on the way up. Then we have the arch. Then we have the thoracic aorta on the way down. Then we penetrate the diaphragm, and immediately the thoracic aorta is renamed the celiac trunk. And then as it gets a little bit farther down, it's renamed the abdominal aorta, and then it bifurcates into the left and right common iliac arteries. Okay, so here we have the ascending aorta, right? The aortic arch, the descending aorta, the thoracic arch. Coming off of the left-hand side, we have the common carotid artery and the left common carotid artery, left subclavian artery, and then we have the brachiocephalic trunk on the right-hand side, which bifurcates into the right common carotid artery and the right subclavian artery. Here's the diaphragm, right? So as we pass through the diaphragm, we rename the thoracic aorta the celiac trunk, and then as we get a little bit further, you call it the abdominal aorta. Blood is traveling downwards to the lower part of the body through this area. Okay, arteries that come off of the thoracic aorta. So if you just look at the thoracic aorta, we have intercostal arteries that come off of the thoracic aorta. What do you think they supply blood to? Obviously, they supply blood to the intercostal muscles. So the muscles that help us breathe, the intercostal muscles, are supplied by intercostal arteries that are branches of the thoracic aorta. Right, the bronchial artery, what do you think that supplies blood to? If you guessed the bronchial tubes of the lungs, you'd be right. The esophageal artery, right? The esophageal artery supplies blood to the esophagus. So it is a branch of the thoracic aorta as well. And then the pericardial artery supplies blood to the pericardium, the membranes that surround the heart. And then just before leaving the thorax, we have some little branches of the thoracic aorta that supply blood to the top of the diaphragm, and those are the left and right superior phrenic arteries. Right, so you can see the bronchial artery here. You can see the esophageal artery here, right? And then you can see the other ones. Okay, so now we travel through the diaphragm and we're in the abdomen. We're below the diaphragm in the abdomen. And we have immediately, we rename the thoracic aorta as the celiac trunk. And then coming off of the celiac trunk, we have the inferior phrenic artery, and then there's a left and right gastric artery for the stomach. There's a hepatic artery, splenic artery, and so on. Okay, so here we have the diaphragm, and then we have the celiac trunk, and then coming off of the celiac trunk, we have all of those things. We have the gastric artery here, and then a little bit lower down here, we have the superior mesenteric artery. Mesenteric artery is supplying blood to the membranes that surround the intestine, the serous membrane that surrounds the intestine. Right, and so you can see all these. They're left and right renal arteries that supply blood to the kidneys. The kidneys are filtering that blood, of course, and taking out the urea, sending it outside as urine. All right, and then coming off of the celiac trunk and the abdominal aorta, so we have all of those things. Now, one caveat, one thing to be aware of is that these arteries are named after the areas that they supply blood to for the most part, but not altogether. So the esophageal artery, for instance, supplies blood mainly to the esophagus, but also to a couple of other places, but we don't include those in the name, and the same is true for all the other arteries. So this diagram is from the OpenStax book. It just shows you the areas where all of these arteries actually supply blood to several areas, right? So that, for example, the left gastric artery up here supplies blood to the stomach and also to part of the esophagus, right? So it doesn't have the word esophagus in it, but it supplies blood there as well. Okay, so the splenic artery, the name suggests that it's supplying blood to the spleen, when in fact it's supplying blood mostly to the spleen, but a little bit of blood to the stomach and a little bit to the pancreas as well. Okay, so the spleen, of course, is a filter that filters bacteria out of the blood and things like that. Okay, so the common hepatic artery supplies blood to the liver mostly, but it also supplies a little bit of blood to the stomach and the gallbladder and a little bit to the duodenum and a little bit to the pancreas. Right, so I'm not going to ask you about these other areas that are supplied by these arteries. I will not ask you about that, but I just wanted you to be aware of the fact that you can usually tell where these arteries are supplying blood to from the name, but that doesn't tell you the complete story. It misses a few areas. Okay, blood traveling to the head. So here we have left and on the right hand side we have the brachiocephalic artery that bifurcates into the right subclavian artery and the right common carotid artery, right? So that we are looking at a right side lateral view of the arteries of the head here. This diagram is actually from the OpenStax book. Remember, the nice thing about the OpenStax book is if you're looking at the PDF file, it's in color, so you can tell that these are meant to be arteries because they're colored red. All right, so you can see that we have the brachiocephalic trunk down here, kind of hidden behind the clavicle. Right, so there's the aortic arch down there at the bottom. And then we have the brachiocephalic trunk, and the brachiocephalic trunk then bifurcates into the right clavicle, the right subclavian artery, and the right common carotid artery, which bifurcates into an external and an internal artery. The external artery supplies blood to the face. The internal artery supplies blood to the brain. You can see that it enters the skull here through the carotid canal, and then ends up supplying blood to the circle of Willis. Okay, so remember that the vertebral arteries travel through the cervical vertebra and they supply blood to the posterior side of the brain. They enter the brain through the foramen magnum and they converge to form an artery called the basilar artery that supplies blood to the posterior part of the brain. And then the internal carotid arteries travel through the carotid canal and feed blood into an anastomosis, a redundant circle of arteries called the circle of Willis. Okay, so here you see the cervical arteries coming up through the foramen magnum and supplying blood to the basilar artery, which supplies blood to the posterior side of the brain. And then the internal carotid arteries enter and supply blood to the circle of Willis, which supplies blood to the anterior part of the brain. So looking at the arm, of course, so the arm gets its blood initially from the subclavian artery. So the subclavian artery runs underneath the clavicle. And then as it kind of heads downwards, it becomes the axillary artery. Right, so there's the axillary artery. A little branch comes off of the axillary artery, which is the humeral circumflex artery that supplies blood to the deltoid muscle here. It's the same blood vessel, but we give it another name the farther down it gets. So then when it gets down to this level, we call it the brachial artery. That's the one we measure blood pressure from. Notice that the brachial artery is sitting in front of the humerus. Right, so it's a relatively superficial artery. You know, none of the arteries are really very superficial, but it's relatively superficial, so that you can cut off the blood flow with a sphygmomanometer when you want to measure the blood flow. Right? And then the brachial artery bifurcates into the ulnar artery here and the radial artery here. So blood is traveling down the arm, of course. when it's traveling through the arteries. It's traveling up when we start talking about the veins. Looking at the blood flow through the leg, the arteries going down the leg, these various arteries. So this is an anterior view of the leg. So we have the abdominal aorta bifurcates into a left and right common iliac artery. Right, so common iliac artery. Common iliac artery then travels through the pelvis and becomes, it divides up into a few other blood vessels, but it becomes the external iliac artery. It travels in front of the ischium, and it starts to travel down in front of the femur, anterior to the knee, right? It travels down in front of the femur. And then just as it gets to the knee, it kind of ducks around behind the knee back here. And traveling behind the knee, it's renamed the popliteal artery because that is the popliteal area, the popliteus. And then from there, some of it divides up even more, and some of it comes back around the front. So we have the anterior tibial artery. We have the dorsal pedis artery on the front here. We have the dorsal arch, right? And so there's also a fibular artery and so on. Okay, this is the posterior view of the leg just to show that the femoral artery travels in front of the femur until we get to the patella, and then it ducks around behind the knee into the popliteal, into the popliteus, and then it continues descending down, becomes a few other arteries. Some of it heads around back to the front and becomes the anterior tibial and so on. Okay, let's move into a discussion of the important veins. Right, so these are taking blood back from the body to the heart. They travel upwards from the legs and the abdomen, and they travel down. They travel up the arms. Blood is traveling upwards in the arms, and it's traveling down from the head. So in the head, we have basically the head drains. Well, if we start from the head, if we start from the skull, you have the internal jugular veins that are carrying blood back from the head. Remember that inside the skull, we had the superior sagittal sinus, the inferior sagittal sinus, the cavernous sinus, and the occipital sinus. We mentioned all of those when we were talking about the nervous system. And what is it that supplies blood to the brain, right? And then those things all drain into the interior, those veins all drain into the interior jugular vein. And then from the internal jugular vein, the internal jugular vein drains into the left and right subclavian veins. Some of them drain into the vertebral veins. And then we have the finally we get down lower down into the neck, and we have the external left and right external jugular veins. In the thorax, we have the left and right subclavian veins that are taking blood over, that are removing blood from the arms. And then we have the superior and the inferior vena cava, which are bringing, the superior vena cava is bringing blood to the heart from the head and the arms, and the inferior vena cava is bringing blood up from the body. The azygous veins are draining blood from the costal region. They're draining blood from the rib cage area, from the intercostal muscles. And then the intercostal veins do that as well. And then there's the esophageal veins that drain blood from the esophagus, drain oxygen-depleted blood from the esophagus. Then if we go down into the abdomen, we have the inferior vena cava, of course. Now notice that when we were talking about the aorta, we gave the aorta two different names depending on whether it was in the thorax or in the abdomen. It's the same artery, but we give it two different names depending on where it is. So we called it the thoracic aorta when it was in the thorax, and then after it passed through the diaphragm, we called it the abdominal aorta. We don't do that with the inferior vena cava. So it doesn't matter whether the inferior vena cava is in the abdomen or the thorax, it's called the inferior vena cava, which makes it simpler for us. So then we have the left and right phrenic veins, which are draining blood out of the oxygen-depleted blood out of the diaphragm. We have the hepatic vein that takes blood from the liver. Do not confuse the hepatic vein with the hepatic portal vein, which I'm going to talk about later. Then we have the left and the right adrenal veins, and the left and right renal veins, which take blood back from the adrenal glands and from the kidneys, respectively. Gonadal vein takes oxygen-depleted blood back from the gonads, the testes, or the ovaries. Okay, so the arms, we have the subclavian vein. If you start way down at the bottom in the hand, you have the palmar venous arches, which deliver blood to the ulnar vein or the radial vein. And then the blood travels up through an interesting anastomosis that consists of in the axillary region, you have all of these veins that are kind of interconnected. But so you start with the palmar venous arches. They deliver blood to the ulnar vein or the radial vein. And then you have the blood delivered to either the basilic vein or the cephalic vein, which are located up here in the upper arm. And then some of them deliver blood to the median cubital vein, which is kind of here in the upper arm. And then you have eventually the blood gets delivered to the axillary vein, right, which is up here, and then to the subclavian vein, and then kind of curling around and dumping the oxygen depleted blood back down into the right atrium rather. Legs, you start from the feet, then you go up the fibular vein or the posterior tibial. It's all interconnected. It's an anastomosis. Anterior tibial, and then up into the popliteal vein, and then also into the great saphenous vein, which is a superficial vein that runs down the side of the leg, and then into the femoral vein, which runs basically in the same place that the femoral artery did in front of the femur, and then into the external iliac and the common iliac veins, and then up into the inferior vena cava. So around this area in the pelvis, we have mirror images of veins and arteries where you have a common iliac vein as well as a common iliac artery, and then you have an external iliac vein as well as an external iliac artery. Okay, so inside the head, right? So we have blood is coming back from the arms. It travels down the subclavian vein and then gets dumped into the superior vena cava. Blood traveling back from the head it's traveling back through the superior sagittal sinus, the inferior sagittal sinus, the occipital, the cavernous sinus here in the middle, and the occipital sinus back here. Some of that drains down the cervical veins, which travel through the cervical vertebra, and some of it travels through the internal jugular vein, and then it all gets dumped back into the superior vena cava. Looking at the blood vessels in the thorax and the abdomen, so here we have the subclavian veins bringing blood back from the arms. We have the hepatic veins bringing it back from the liver, and so on. Right, and we have the superior and the inferior phrenic veins, which take blood back from the diaphragm. Okay, looking at the leg, this is an anterior view of the leg. So we have, starting down here with the dorsal venous arch and the digital veins, the blood will travel up the fibular vein or the tibial vein, right, and then some of it will go into the popliteal vein behind the knee once again. Some of it travels upwards through the great saphenous vein, which is interesting if you're a phlebotomist because it's a superficial vein that you can draw a blood sample from. You can't really draw a blood sample from the external iliac vein or the common iliac vein because it's too deep. They're too deeply buried under muscles and things. Okay, here's a posterior view of the blood vessels, the veins of the leg. So you can see the popliteal vein here traveling behind the knee, the great saphenous vein traveling on the medial side of the leg, a superficial vein, and then the femoral vein, and so on. Okay, let's pay special attention to the arm because if in the event that some of you might want to become phlebotomists, you have to be very familiar with these veins in the arm. Okay, so up here we have, well, let's start at the bottom. So we start with the digital veins and the palmar venous arches that are sending blood up to the ulnar vein and the radial vein. Right, so we get the blood that far. And then some of the blood continues upwards into this vein, which is called the basilic vein, or into this vein, which is called the cephalic vein. Right? And then there's one that crosses over here called the median cubital vein. The median cubital vein is the most common vein from which to take blood samples. And so what you do is you tie a tourniquet around the brachial part of the arm. The blood is trying to get from the hand back up the arm, and you're blocking it, so that makes the veins bulge because you're increasing the pressure by blocking the veins temporarily. And then if the veins bulge enough, you can see where the median cubital vein is, and then you stick a needle into it and take a blood sample. Right, and then if we travel farther up the arm, there's a deep vein called the brachial vein, which you can't get to because it's too deep, but the median cubital vein is quite easy to get to. Right, and so then the brachial vein becomes the axillary and the cephalic veins, and then into the subclavian veins, and then into the superior vena cava. Let's look at the arteries and the veins that supply the digestive system for a minute. Okay, you know that when you digest food, it gets broken down in the small intestine. The food, the amino acids and the lipids and so on get absorbed by the veins that surround the small intestine. And from there, they're carried to the liver. The liver acts as a filter, which filters out any toxic substances from the food that we've broken down. One of the top toxic substances is ammonia. Another one is hydrogen peroxide. The liver is a good filter that will detoxify all of those things. So we have to have some way to get the blood from the intestine to the liver. And what happens is you have a network of these veins that surrounds the intestines, and that network of veins is referred to as the hepatic portal system. The hepatic portal system. And all of those veins converge into one large vein that's called the hepatic portal vein, which takes all of those nutrients and all of that blood into the liver to be filtered and detoxified. Okay, so there's some other veins. There's a spleen vein that comes out of the spleen, the splenic vein, pancreatic vein, and then superior mesenteric and inferior mesenteric. The superior mesenteric vein takes blood from the small intestines, some of them, as well as from the ascending colon, and then the inferior mesenteric veins takes the rest of the blood from the colon. Okay, so you're just seeing here where the inferior mesenteric veins go and the superior mesenteric veins. And the most importantly here we have the hepatic portal system, right? And all of these veins eventually converge into the hepatic portal vein, which enters the liver on the underside, on the inferior side of the liver. Okay, let's talk a little bit about potential careers as a phlebotomist. The science of drawing blood is called phlebotomy. The science of puncturing veins to put in intravenous drugs is called venipuncture. Venipuncture. Okay, so if you've been to the hospital, you know that sometimes they take a bag and they hang it from a little metal tree, and then they put a needle usually into the back of your hand, into a vein. But let me ask you something. If you were going to take a blood sample out, would it be easier to take it out of an artery or a vein? Well, the fact that arteries have thick walls makes it difficult to poke a needle into an artery, but it can be done. It's just harder. Generally, blood samples are taken from veins, and so phlebotomists have to be familiar with all of the superficial veins. If you want to deliver drugs into the bloodstream, let me ask you, would you attach a hose going into a vein or into an artery? Well, the answer is you would put the IV hose into a vein, because if you put it into an artery, the blood pressure is high enough in the artery that instead of delivering the drugs into the bloodstream, you might end up just pumping blood back into the bag. So the blood, instead of the drugs going into the artery, the blood would come out of the artery into the drug bag. So that's the reason why you use intravenous bags and intravenous drugs. You put them into veins rather than arteries. So venipuncture is the art of puncturing veins to let IVs in or to draw blood out. Phlebotomy, or a phlebotomist, is the profession of drawing blood. You can get certified as a phlebotomist at BCIT, which is in Burnaby. That's the British Columbia Institute of Technology, or at Vancouver Community College, which is located on, I believe it's on Clark Street and 25th. Now, here's another career that you can take, which is something called a medical laboratory assistant. It's an 8-month long program at BCIT. Or you can also become a certified medical laboratory technologist, which is called abbreviated CMLT, which is a 2-year program. Okay, so a certified medical laboratory technologist is a technician who does basically all of these jobs in the laboratory. They analyze the urine, they analyze the feces, they analyze sputum, they do the microbiology tests, they do the blood tests, and in addition to that, they are certified phlebotomists. So if you have a medical laboratory technician certificate, you can work as a phlebotomist as well. Whereas if you just have the phlebotomy certification, you can only work as a phlebotomist. Okay, so it is medical laboratory assistant is kind of a watered down version of the medical laboratory technologist. If you're interested in working in hospitals, but you're a little bit squeamish about, if you don't want to spend 15 years in school to become a medical doctor. If you're interested in working in hospitals anyway, it's a nice place to work. It pays a fairly good wage. You're working with people, but not under very pleasant circumstances, sadly. But if you want to do that kind of a job, one of the careers that I recommend is going in for medical laboratory technologist. You're a member of the same union as the nurses, the hospital workers union here in BC, so you get the same salary as a nurse, but it's a much less unpleasant job. Being a nurse, to be honest, is a very stressful job. Very hard, very stressful job. It takes a very special kind of a person to be a nurse. To be a medical laboratory technician, you can do some of the jobs that a nurse would normally do, but it's a much less stressful job. Nurses and care aides always tend to be in a bit of a panic because they have so much work to do. You have a much easier life if you're a medical laboratory technologist. Okay, now so becoming a medical laboratory technologist is a 2-year program. You could go there right now to BCIT if you want. The only requirement is a high school diploma. So if you graduated high school, you can immediately enter the medical laboratory technician program. Most of the time people don't. Most of the time people get an AD degree or even a Bachelor of Science degree before getting the CMLT certificate. But that's totally up to you, the order that you want to do things. Now, if you have the CMLT certificate, you can get a job. So if you don't want to go all the way to getting a bachelor's degree, you don't have to. If you don't want to go all the way to getting a PhD or something like that, you definitely don't have to. So if you get a medical laboratory technician certificate, you can get a fairly good job in a hospital. And then if you still want to complete a bachelor's degree, you can go to UBC, and they have a very obscure program. I'm telling you about it because I used to work in that program, but it's almost a secret that UBC has this course, and the course is designed for medical laboratory technicians who have that certificate to do 3rd and 4th year only, and then they give you a Bachelor of Medical Laboratory Science degree. Right, so you don't have to spend 4 years getting a Bachelor of Science degree. You can get it in 2 years if you've spent 2 years getting a certificate as a CMLT. And if you get that certificate as a CMLT, that will give you the opportunity to get employment in a hospital. Right? So to me, that sounds like a very sensible career path. You do 2 years at BCIT and you get a CMLT. And then if you can get a job at that point, you can stop going to school if you're tired of school, which I can understand. But if you still want to get a bachelor's degree, you go to UBC and you do the BMLSC program. Okay, if you've got a bachelor's degree, if you want to, you can go into medical school if you did well enough, if you have high enough grades. And I'll tell you that there's a little bit of, on the admission boards in the medical schools, there is a little bit of a bias in favor of accepting students who have a BMLSC degree as opposed to some other Bachelor of Science degree. So if you apply to UBC Medical School and you have a Bachelor of Science in cell biology or you have a Bachelor of Science in genetics, and you're competing against somebody who has a Bachelor of Medical Laboratory Science degree, they will probably give preference to the BMLSC degree holder. So your chances, if you have a BMLSC degree, just a little bit of advice, informal advice from me, if you have a BMLSC degree, your chances of getting into medical school are better than if you have some other type of a bachelor's degree. So that's a potential career path. All right, so okay, I already asked this question. What if you want to get drugs into the system? Would you use a vein so if you put drugs into the system, would you put them into a vein or an artery? You wouldn't want to put them into an artery because the blood is at high pressure in the artery. So instead of the drugs going into the artery, probably blood would come out of the artery into the drug bag. A phlebotomist. By the way, I was partly trained as a phlebotomist once. I hated it. I had to do it for another job that I had at one time. But when you go into phlebotomy school, or if you're doing the medical laboratory science diploma, you start out by learning how to stick needles just underneath the skin of a banana, because the idea is the veins that you're trying to draw blood out of are located just under the skin. So you don't want to stick the needle in too deep and miss the vein entirely and possibly hit the medial nerve, which is underneath it. You very gently stick the needle under the skin and just barely get into the vein. And if you do it that way, it hurts less, right? So you're inflicting pain on people, which is not very pleasant. So the first step in training to be a phlebotomist is you stick a needle under the skin of a banana. When you become an expert at doing that, after you've become an expert at doing that, they give you a rubber phlebotomy arm to practice on. This arm is made out of rubber and it has some artificial veins inside it that you can see there. You fill up the artificial veins with a liquid so you can tell when you've actually hit the vein. And then when you become an expert at using the phlebotomy arm, we have one in the Columbia College biology lab if you've ever seen it. Then the worst part of the training course is that you have to practice on each other. Right. So by the time you get to be poking needles into patients, you're a little bit of an expert because you've had some practice. Who on earth would volunteer to practice for that? Well, other phlebotomy students. So you have to, that's the worst part of the training. The scary worst part of the phlebotomy training is that you have to practice on each other. And you don't just practice taking blood samples from the median cubital vein, from the veins in the arm. You have to practice taking blood from the cephalic vein and other veins as well that hurt a lot more when you push a needle into it. So it is a good career, but beware that you have to do this really unpleasant stuff to get trained in that career. All right, so where are the preferred places to stick IV needles? One of them is on the dorsal venous arch, and I'll show you where that is. That's on the back side of the wrist, and the other place is in the anastomosis of veins on the dorsal side of the hand. That's called the metacarpal plexus. Okay, so these are the preferred spots for putting IV needles if you're trying to get drugs into the system. So you've probably seen this. You hang a bag full of drugs on this tree. It goes through a peristaltic pump and it's usually stuck into the hand. The needle is stuck into the dorsal venous arch or the metacarpal plexus on the back of the hand. And if it's done properly, you only leave the needle in one of these veins for a few days, and then you have to take it out and put it into another one because the needle does damage the vein, right? So you have to keep on switching veins. So if you're in the hospital for a long time, getting IVs for a long time, it's kind of hard on the veins on the back of your hand. Okay, what about drawing blood samples out? Okay, so the first thing you have to do is you take the arm and you tie a piece of rubber around the arm that's called a tourniquet, right? And so the blood is trying to get from the hand back up the arm, and you've tied this rubber piece of rubber around the arm to prevent it. That causes the veins to bulge, and then you feel around with your finger to find the median cubital vein. So you palpate. Palpate means to feel with your hand, or if you say that you feel a bump under the skin, you say that's a palpable mass. Palpable just means you can feel it with your fingers, feel it with your hands, right? So you tie a tourniquet around the arm, that makes the veins bulge. You fish around with your fingers until you can palpate the vein, and then you stick the needle into either the median cubital vein, which is the preferred vein, or the cephalic or the basilic vein. And the blood is actually sucked out of the vein because you suck the blood into a test tube that's called a vacutainer, and the vacutainer has a vacuum inside. So the vacuum will actually suck the blood quickly out of the vein, so you don't have to leave the needle in the person's arm any longer than you need to. Okay, so here you put a tourniquet on, right? And then you palpate for the vein. There's the median cubital vein. And then as soon as you've stuck the needle into that vein, you release the tourniquet, you snap it away, and then the vacutainer sucks the blood quickly into the tube. Okay, so well, obviously before you stick the needle in, you have to sanitize the area. So you rub it with some alcohol to, there's bacteria. There's a lot of bacteria on your skin, which if that bacteria got into your bloodstream, it would cause a lot of trouble. You get rid of a lot of it by rubbing with an alcohol swab. You don't actually get rid of all of it. So occasionally veins do get infected, but this kind of keeps the bacteria to a minimum. Right, so once you've got the needle in the arm, you can remove the tourniquet, and that allows the blood to flow through the needle. But if you've seen somebody taking your blood, or you've seen somebody taking someone else's blood, you see that what they do is the first thing they do is they stick the needle into the median cubital vein, and then they stick the needle, the thing that they're manipulating, the thing that they're holding has a sharp point on both ends. So one end of the needle goes into the arm, and the other end of the needle is used to pierce the lid of these vacutainers, one of these vacutainers. Okay, so once the lid is pierced, the blood is sucked into the tube by the vacuum. And if you're a phlebotomist, you have to learn the color coding of these lids, right? So the lids mean different things, and what are you going to do with the blood after you've got it? Depending on which test you're going to do, there's usually some chemical, a little bit of chemical that's already in the tube, and that will assist in whatever test you're doing next. And so as a phlebotomist, you need to know what the colors of the tubes mean. Okay, so here are the preferred sites for drawing the blood samples. As I said, the median cubital vein is the favorite, but you can also, the medial vein, which basically runs across the elbow. It's easy to find. If you can't find it, or there's some other reason why you can't use it, you can also use the cephalic vein or the basilic vein, which are both superficial veins. So all three of those veins are close to the surface and easy to see and easy to get to. All right. Consider the fact that you're drawing blood from either the median cubital vein, the basilic vein, or the cephalic vein. Consider the fact that running just underneath the median cubital vein, you have the medial nerve, and just under the basilic vein, you have the ulnar nerve, and just under the cephalic vein, you have the radial nerve. So if you stick the needle in too deep, it will go right through the vein and into the medial nerve or the ulnar nerve or the radial nerve, and that will cause excruciating pain. So, as I said, to be a good phlebotomist, you have to learn how to stick the needle just under the skin so it just gets into the lumen of the vein rather than going beneath the vein and hitting one of these nerves. Right, so there are the locations of the medial, the ulnar, and the radial nerves, which are prime targets for getting hit by the needle if you're sloppy, if you're a bad phlebotomist. Okay, so the nerves are deeper, so you don't insert the needle too deeply. That's why you practice on getting the needle just under the skin of the banana. Sometimes they use an orange, but bananas work better. Okay, let's learn a couple of, we're going to learn what three of these color codes mean. We're going to learn what three of these colors mean for the tubes that you're putting the blood into. Okay, so the collection tubes. Okay, so the orange tube contains something called thrombin, which is used to cause the blood cells to clot quickly so that you can look at the serum. And I'm going to go over these things again when we talk about the blood. Right, so the orange vacuum container contains thrombin, which causes the blood cells to coagulate so that you can take the serum out without getting the blood cells. So you want to separate the blood cells and the serum. The quickest way to do it is either you can centrifuge the tube and spin it to separate the blood cells from the serum, but you can also cause the blood cells to coagulate so that they fall to the bottom quickly, and then you just take the serum. Okay, the tube with the purple lid is for a complete blood count. It contains a chemical called EDTA. We won't learn the name, what the full name is, but I believe it's like ethylene diamine trichloroacetic acid or something like that. It's a long chemical name. EDTA is used as a preservative. It prevents bacteria and other things from growing in the blood. So it doesn't do anything to the blood. It doesn't make it clot. It doesn't prevent. It actually prevents it from clotting because it does actually prevent it from clotting because what it does is it chelates. Chelation means to grab hold of and steal. It chelates the metal cofactors that are in enzymes of in the various enzymes that make the blood clot. It also chelates or steals the metal cofactors that are in the enzymes that keep bacteria and fungus alive. So EDTA is a preservative that prevents the blood from going stale, prevents it from clotting, prevents contaminants from growing in it. You can use the purple tube for the complete cell count, a CBC. That's where you put the blood sample into a machine called a flow cytometer, and it literally counts how many red blood cells, how many platelets, how many leukocytes you have in that blood. So that's one purpose. You can also, in the old days, it was also used for DNA fingerprinting when they were trying to identify criminals. So if you have a murder scene and there's some of the victim's blood there, and then there's some of the killer's blood as well, you can do what's called a DNA profile. You may remember that there have been some famous cases where blood was found at murder scenes, and the defense attorneys for the criminals that were put on trial were trying to convince the jury that that blood was planted there by the police, and the way you would prove that was to use a machine that can detect EDTA. And so if the police planted your blood there, they got it from a vial of your blood that a phlebotomist took, and they didn't realize that there was EDTA in it. There have been a couple of really high-profile cases in North America where that's happened. Okay, finally, the light blue cap is used for something called the prothrombin time test, or the PTT test, and it's a measurement. It's when you deliberately allow the blood to clot and you measure how fast it clots. That's called the PTT test, right? So the orange cap tube is meant to coagulate and clot the blood. The purple cap tube contains EDTA. It preserves the blood. The light blue cap contains a citrate buffer, which allows the blood to clot at a certain temperature. So you can do a PTT test. Right, so the thrombin is added. So as soon as you put the blood into that tube, it will clot, and then you can take the serum off the top. The purple tube contains EDTA. You can use it to look directly at the blood. The EDTA is just there as a preservative. So we've done what's known as a blood smear here. You can also pour the blood into a machine called a flow cytometer, which will give you a computerized readout, as you see here, a CBC, or a complete blood cell count, a complete blood count. You can use it to do DNA profiling for crime scene investigations. You can also use DNA profiling to do maternity tests and paternity tests, where you have you have a child and it's not clear who the father is and you want to find out, so you do a DNA profile. So that's another use for, you would take a blood sample and put it into a tube that has EDTA in it. But I should mention that DNA fingerprinting these days is no longer done with blood samples. That went out of style probably 10 years ago. And now what we do is we take buccal swabs. So you take a swab and you take the buccal cells from the inside of the cheek that have nuclei in them, and that's actually a much better source of DNA than blood. Because think of this, you'll be learning about this in the next lecture, but blood cells are 99% of the cells in blood are red blood cells, and red blood cells don't have a nucleus. So that means that only 1 out of every 100 cells is a white blood cell, and only the white blood cells have a nucleus, and only cells that have a nucleus contain DNA. So you're wasting your effort by trying to do a DNA profile on blood when only 1 out of every 100 cells in the blood can be used to extract DNA from, right? So it's much better to take buccal cells from the cheek, which is a much better source of nucleated cells. So the PTT test, you allow the blood to clot, you measure the amount of time it takes to clot. It usually takes between 11 and 13 seconds. You compare the amount of time that it takes the blood sample that you're testing to clot. You compare that time to a control sample that you know is good blood. And then if it takes too long to clot, or if it clots too quickly, either of those things indicates some kind of a problem. All right, let's look at some quickly look at blood vessel pathologies. Okay, atherosclerosis, of course, is where you build up plaque. That's mainly cholesterol with lipid. So the artery becomes occluded, right, or stiffened, right, stenosis or occlusion. So the blood vessel becomes narrower because you have all this junk, this garbage called plaque is built up on the inside. The more narrow it is, the more easily blocked by a loose blood clot called an embolus, and therefore you can have myocardial infarctions and things like that. Right, so coronary artery disease is where the coronary arteries become occluded, they become narrow. You can have hemorrhages or aneurysms. An aneurysm is where a blood vessel weakens and you get a bulge on the side of the blood vessel because it is weakened. Usually the connective tissue has become weakened. And then if that blood vessel bursts, you have a hemorrhage, right? So hemorrhaging means bleeding. Varicose veins is where the veins become stretched, usually in the legs or the arms, and you have poor venous return. And then sometimes that can lead to something called deep vein thrombosis, which is where if the veins in the legs become stretched so that the blood doesn't circulate, then the blood just sits there stagnant. Stagnant, of course, means not moving. So the blood sits there stagnant and forms clots. Those clots can then sometimes get out of the veins and into the bloodstream and cause blockages cause embolisms. Okay, so atherosclerosis is a buildup of plaque inside the arteries. Plaque is a mixture of calcium, lipids, and cholesterol. Sclerosis means narrowing of the arteries. Occlusion means narrowing of the arteries as well. If you have a blood clot, which we'll talk about in the next section, if you have a blood clot, that is referred to as a thrombus. A thrombus is a blood clot that is localized to one area of a blood vessel. If it breaks loose and starts traveling around the body, that's referred, we give it another name and we call it an embolus. If it blocks a blood vessel leading to ischemia and then hypoxia and then necrosis, then it can cause death of tissue, and the whole event that causes the death of tissue is referred to as an embolism. Right, so here we have an occluded artery. You can see this cross section shows that plaque has built up on the inside, narrowing the lumen, and therefore it's more easily blocked by an embolus. Okay, so here we have a buildup of plaque causing occlusion of the arteries, stenosis of the blood vessels. So coronary artery disease is where you have atherosclerosis of the coronary arteries specifically. You fix it with a balloon stent, or you do something called a coronary bypass. A coronary bypass is where, rather than trying to unblock the artery or to widen the artery, you probably do that as well, but you also, what you would do is you would take a vein from a leg and then you would graft it onto the heart, graft it onto the coronary artery, and go around the occluded area. Right? So if you do that once, it's a single bypass. If you do it with two veins, it's a double, a triple, and so on. Right, so here we have a blocked artery. Right, we have a blocked coronary artery. This is a myocardial infarction because the tissue is dead down here. Right, so we want to avoid that blockage. We can either unblock it or we can bypass it. Okay, so here's if we have an occluded artery, that thing is just sitting there, an occluded coronary artery, it's just sitting there waiting to be blocked. We can either open it with a stent, a balloon stent, or we can bypass it, or both. Okay, so here what they've done is you take a vein out of the leg because it's compatible with your veins, and then you graft one end of it onto, what they've done here is they've grafted one end of it onto the subclavian artery, and they've bypassed the blockage, which is supposed to be here, for example. So there's a blockage or an occluded coronary artery here. You simply graft another blood vessel around it so that it bypasses the blockage. Easy, right? If you do that twice, right, we'll put this one here, we'll bypass this, and then maybe there's a blockage here, we'll take another one and we'll put it over here on this side. We'll bypass that, that's a double bypass. If you do it 3 times, that's a triple bypass. If you do it 4 times, that's a quadruple bypass. Right, so these are coronary artery bypass grafts, or CABGs. All right, you've probably seen tires, bicycle tires and things like that, where if you get a bulge in the inner tube of your bicycle, you know that you have to replace it because it's going to break very soon. So the rubber is bulging like that because it became weaker. Right now, the same thing sometimes happens to the connective tissue in an artery. The connective tissue becomes torn or weak, and then maybe the layer of smooth muscle bulges out from underneath the tunica externa, and then you know that it's going to burst, and so you have to repair it. Right. So those things are called aneurysms when you have a weakening of the blood vessel, and then it's in danger of bursting. If it bursts, you have a hemorrhage. Hemorrhage means bleeding. Hemorrhage means bleeding. Aneurysm just means a bulging, weakened artery. Okay, so this is the abdominal artery, right? And if you have an aneurysm of the abdominal artery, it actually presents as back pain. So you feel like you've got a pain in the back. But that's an example of referred pain. It's actually caused by bulging, weakness and bulging of the abdominal aorta. Okay, now we have a couple of other terms that we have to learn, which are ways to describe the shape of an aneurysm. If the aneurysm bulges on only one side, it's called a saccular aneurysm. If it bulges on both sides, it's called a fusiform aneurysm. Right. So, and then obviously if it bursts, you have hemorrhage, and that's called a ruptured aneurysm. So we have saccular aneurysms that bulge on one side. The weakness is on one side only. A fusiform aneurysm is where it's weakened all around. You may remember the word fusiform when we talked about the shape of muscles. We have fusiform muscles that have a wide belly and a narrow origin and a narrow insertion. Okay, so here's a brain aneurysm. This is usually lethal if you have the blood vessel bursts in the brain and then you get compression of the brain against the skull. That's usually lethal. Okay, so we talked about a saccular aneurysm versus a fusiform aneurysm. There's another type called a false aneurysm, which is where you just have a growth of tissue on the artery, so it looks like it's bulging, but it's not actually a bulge, it's a lump of tissue. And then finally, there's another type called a dissecting aneurysm, where you get a tear in between one of the 3 layers of the artery. Okay, so here's a saccular aneurysm, fusiform aneurysm, false aneurysm, which is just the growth of tissue. And here, notice that we have a tear between two of the three layers that surround the artery, which is called a dissecting aneurysm. Right, so you remember, have you ever had a cheap coat with a lining, and you put your arm inside the arm of the coat, and then instead of coming out of the sleeves, it just bangs into the bottom of the lining, and you say, "Oh, I have to get rid of this jacket now." That's basically what a dissecting aneurysm is. Right, so here you can see a dissecting aneurysm of the aorta. So the blood is flowing at high pressure in between the layers of the aorta, which is bad. Some places can tolerate a dissecting aneurysm better than others. All right, what are varicose veins? If you have veins that have become weak and loose, the blood doesn't uh, usually with defective valves, the valves become loose, so they're not doing the proper job of sending the blood all in one direction. So the blood just kind of meanders around and doesn't return to the heart, so you have poor venous return. And if the blood sits in it sits in one place, if it stagnates, it sits in the same place for a long enough period of time, it will actually form clots, and that clots can cause problems, as we've seen. They can cause embolisms. So deep vein thrombosis is where you have basically varicose veins of the deep veins as opposed to the veins on the surface, and that could result in a lot of embolisms being formed. So there are emboli. So the blood sits still. Normally the blood flows. If the blood is sitting still, it tends to clot. That's what blood does if it sits still for a long period of time. And then you end up creating these emboli that circulate around the bloodstream, blocking blood vessels and causing ischemias. Okay, if you do the PT test, how long does it take for the blood to clot? Think about that. If you had this happening, would you have a longer clotting time or a slower clotting time, or a longer clotting time or a shorter clotting time? All right, so this has been a long lecture. I apologize for that, but we're on a time constraint this semester. So to summarize, we talked about physical differences between arteries and veins, particularly the presence of valves and veins and so on. We talked about the properties of capillaries, how thin they are, how the hydrostatic pressure is greater at the arterial side than the versus the oncotic pressure being higher at the venule side. We talked about how to measure blood pressure. We talked about the difference between systolic and diastole. We talked about ways to regulate blood pressure, increasing or decreasing the pulse, and so forth. We talked about the lymphatic system as a backup drainage system. We talked about what anaphylaxis is. We talked about the usage of blood around the body and how the brain usually has the same amount of blood. And then we learned about we learned the names of most of the important blood vessels in the body. Thank you very much for sitting through all of that. Part 3 of the cardiovascular lecture is on the blood itself, and I'll see you at that lecture.